pericarditis and myocarditis. You'll find now in block 2, we're going to be focusing on the vascular diseases that impact the cardiovascular disease, or the cardiovascular system. To start off with hypertension, and then we'll talk about atherosclerosis and lipid disorders, and then we'll go into ischemic heart disease, acute coronary syndromes, and then into peripheral arterial diseases and peripheral venous diseases. Okay, so this block really focuses on the vascular diseases. And we kind of have to talk about this first before we talk about the topics in block 3, because you'll see in block 3, so much of what we talk about is because of these vascular diseases. So I have to give you that context before we can really start talking about heart failure and all those types of things. So that's how the sequencing will go. This block 2 test conceptually is not difficult, but there is so much more information because we actually have one additional lecture block in this block that what I get in all the other blocks. So don't be falsely reassured if you did well on this exam. The second exam is challenging because there's just a lot more information, a lot more pathologies that we're going to talk about. And we're going to talk about how you treat all of those different pathologies. And they're all different. So make sure you're keeping up with the studies on this, or else that block 2 test will sneak up on you. Okay. All right. Questions before we get started with today's lecture? So we're going to do 2 lectures about hypertension. This one's going to be about pathophysiology. It's going to talk about essential hypertension and then some of the treatments for it. Okay. Tomorrow we're going to talk about secondary hypertension cases or disorders, and then we're going to talk about hypertensive crises. Okay. But today we're going to really focus on the essential side and how to manage with some of the basic antihypertensives that we get. But I wanted to start off with a clinical case. So you have a 50-year-old female who has a history of hypertension that presented to your clinic for follow-up for elevated blood pressures. On review of medical history, she's had hypertension for the past 20 years. She insists she's compliant with all of her medications. Currently, she's on 3 medications for hypertension. She's also taking a potassium supplement in addition to increasing dietary intake of potassium for persistent hypokalemia. Blood pressure in clinic today is 210 over 130. She denies any symptoms such as headaches, visual changes, or chest pain. Patient is directed to go to the local ER because she was in a very rural area that didn't have a hospital. The closest one was about 40 minutes away in upstate New York. And, oh, by the way, she was told she couldn't drive because they were concerned about her blood pressure. It was snowing, and there was snow on the roads. So instead, they had their teenage daughter, who just had a driver's permit, drive the 40 minutes to get her to the hospital. She was admitted to the ICU for hypertensive emergency with IV antihypertensives. And then she was found at the time, in addition to having that elevated blood pressure, she was found to have potassium still low at 2.9 despite the massive doses of potassium that she was consuming. So we'll come back and visit that clinical case in a little bit. So hypertension, so common, and we know it's one of the biggest risk factors for heart disease, but how common is it really in the United States? According to the CDC, they say hypertension affects nearly half of U.S. adults, okay? About 48.1% or 119 or 120 million adults in the United States have hypertension. And that's using the criteria of blood pressure greater than 130 over 80, okay? About 1 in 4 adults with hypertension actually have their hypertension under control. So that means 75% of patients with hypertension do not have their blood pressures at goal. So are we really adequately treating and managing our population and addressing the population health if 75% of patients who are at high risk of cardiovascular disease are not having one of those risk factors actually taken care of? But the CDC goes even further. about half of adults with uncontrolled hypertension still have their blood pressure greater than 140/90. So these are people who are potentially taking meds for their blood pressure, but they still are not even, they still qualify as a hypertensive patient despite that medication treatment that they're on. About 34 million adults who have been recommended to take medications for their blood pressure actually have never even started it, whether it being that they just didn't get it prescribed or they got it prescribed, they just didn't pick it up or fill it, because most patients with hypertension don't experience any symptoms, right? They don't know, there's nothing there that is telling them that they need to get this thing taken care of, because they're not having that negative kind of reinforcement of, I've got a problem, I need to take care of it, right? When you think about some of the other diseases that we encounter, somebody with asthma has an asthma attack, has symptoms related to that, they're going to manage it, right? But hypertension, in the vast majority of your patients, there's no symptoms right now, but there's a problem. But fast forward 10, 15, 20 years from now, that damage that's occurring right now will take effect. And now they're actually going to be either dead, or they're going to have had their first or their second MI, or they're going to be in renal failure, right? So just because they don't have any symptoms right now does not mean that there isn't a severe morbidity and mortality associated with this condition if left unchecked years from now. But in 2021, we had almost 700,000 deaths in the United States that could be attributable to hypertension. So height of COVID, still 700,000 people died with hypertension as a component leading to their death. So this is a major problem in the United States. If you look at the map showing patients, the prevalence of patients with hypertension greater than 18 years of age, you can see it's really kind of focused here in like the Appalachia area, right? Right there. So it makes you wonder, well, why is that the case? Why is it that that population in Appalachia is at high risk for having hypertension, or the prevalence of hypertension is so large? Well, let's compare to the map on the top right, our obesity rates. Okay, look at that obesity rate in that area as well. Kentucky and Pennsylvania, you need to do better. Even Guam can report their obesity rates, which haven't been stationed on Guam for 2 years. That's pretty amazing. But you can see the obesity rates are at the highest in that region of the country. So is there a correlation or causation associated with obesity and hypertension rates? One would think, right? But yeah, if you're in from any of those states, hypertension and obesity rates are much higher than the average in the United States. But one of the things you're going to see when you get more experience with practicing medicine is we don't agree on what the definition of a condition actually is, right? So if I say hypertension, define it, you're going to give me a number, right? But what is that number? It kind of depends on which society you believe or want to follow their guidelines. So these are 3 of the top societies that manage or provide recommendations for the management of hypertension. And you can see they don't even agree with the definitions of what hypertension actually is. Okay, so JNC is kind of family medicine tends to follow JNC criteria more than the other ones, but that stands for Joint National Committee. The ACC, AHA, so American College of Cardiology and the American Heart Association, they have their own, and like your inpatient medicine, internal medicine tends to follow those. And then there's the International Society for Hypertension. So think of this more of other nations. This is kind of the society that they follow. But look at what their definitions are, okay? They kind of agree with what a normal blood pressure is like, but they don't agree on what stage 1 hypertension is. You can see JNC says greater than 140/90 is now stage 1, but ACC-AHA is a little more conservative, and they say anything more than 130/80 is hypertension, or stage 1 hypertension. But look at stage 2 hypertension definition. JNC says anything greater than 160/100 is stage 2. That's pretty significant of a difference when you compare it to the ACC-AHA, which says anything greater than 140/90 is considered stage 2. So, depending on the society you follow, will determine how you define these different things. Now, in class, we are going to use this definition. So the ACC-AHA is going to be the definition I'm going to test you on. But just know, as you go into phase 2, your preceptor may follow one of these other guidelines and their management recommendations, and you just need to be familiar that there are other recommendations out there. Okay? And it's okay if you decide that you want to follow the JNC guidelines. The biggest thing that you're going to need to do is just document it in your note. Because then anybody coming after you, reading your note, be like, oh, okay, they're following JNC or they're following ACC-AHA. That explains why they're doing X, Y, and Z for this patient. Okay? So just document which guidelines you're following. But the diagnosis of hypertension should not be based off of just a single abnormal blood pressure. Okay? There's lots of factors that could go in to affect your blood pressure at this moment. You want to show that there is this persistent elevation in their blood pressure. So you're going to need at least 2 to 3, depending on the guidelines, you're going to need at least 2 to 3 abnormal blood pressures in order to establish that diagnosis of hypertension, okay? And it can't be take blood pressure, 1 minute later take it again, and then 1 minute later take it again, and now you got your diagnosis, right? You've got to do it in separate occasions, separate days. If you've ever worked in a military clinic, we always talk about the 5-day blood pressure check. It doesn't really follow guidelines, but it just shows you have to come in at least several days to get that blood pressure diagnosis, okay? Some definitions that you need to be familiar with. So essential, also known as primary hypertension, we don't know why this person has it. There's theories out there, but we don't have a specific identifiable condition that's causing their blood pressure to be elevated. And in the vast majority of your patients, this is what you're going to see. And think of primary hypertension as being the disorder, not a symptom of something else, okay? Whereas when we look at secondary hypertension, there is a different pathology that's present that happens to have as a symptom hypertension, okay? And we'll talk about those things tomorrow, but just know that there is a difference between primary or essential and secondary hypertension, okay? Other definitions to be familiar with, so white coat hypertension. This is probably going to be one of the most common excuses your patients are going to say as to why they have high blood pressure. They're nervous to see you, right? Because whenever you go to the provider's office, is it for good news? Not unless you're going to OB, okay? Rarely does anybody go to their doctor to get good news. Usually they associate it with bad news, being lectured to do things differently, make changes, or we're going to stick needles in your arm and give you vaccines or other treatments and those types of things, right? And if you're in the civilian sector, how much is it going to hurt your wallet, right? So folks coming to us get nervous, and that causes that fight or flight response, that sympathetic nervous system overdrive, which then raises blood pressure, okay? So white coat hypertension, if somebody truly has it, it's whenever they come to the doctor's office or the provider's office, their blood pressure is elevated. But if I took that blood pressure at home, it'd be normal. Okay? That is the definition of white coat hypertension. Okay? Masked hypertension is much more challenging to treat because with masked hypertension, in the office, it's normal. For some reason, you give them a calming effect and it lowers their blood pressure. But when they go home, their blood pressure spikes. Maybe they have a bad or horrible home environment, don't feel safe, those types of things that cause that blood pressure to go higher. And unfortunately, if this is a condition that typically doesn't have symptoms, and the screening tests that we do in the office to test for this are coming back normal, what's the likelihood of us catching this condition early? Probably unlikely, right? Unless they just happen to have a blood pressure cuff at home. So usually those folks with masked hypertension don't come in and get evaluated until they start to have symptoms from a complication related to the disease. And then resistant hypertension is another definition that you might hear. And this is patients who are on at least 3 antihypertensives and their blood pressure is not getting to goal despite being compliant with their meds. So they have to be taking those 3 meds appropriately as prescribed, but their blood pressure still does not get down to goal. Okay? So that's resistant hypertension. So we talked about in order to diagnose it, you have to have at least 2 or 3 abnormal blood pressures that meet the definition of whatever the society of hypertension that you follow. With ACC-AHA, we say that 2 to 3, where the systolic is greater than 130 or diastolic is greater than 80. And the reason that we have to have that 2 to 3 is there's so many different things that can cause us to have a false elevation in their blood pressure. And think about it. If we do something inappropriately when we're taking a blood pressure, then we start them on an antihypertensive, but they normally have normal blood pressures. Imagine what's going to happen to their blood pressure on that medication. It's going to lower it even more, right? So somebody who's like, 1-teens, they start them on a medication because I inappropriately took their blood pressure. Now I'm dropping their blood pressure to like 95. Now they're passing out, feeling lightheaded, feeling dizzy, hurting themselves, hitting their head, those kinds of things. So you can imagine we want to make sure we're diagnosing these patients correctly. So what can we do as medical providers to ensure we're getting an accurate assessment? The most common one is going to be the proper sized cuff. So if you have somebody who has biceps 20 inches round and you put the blue sized cuff on, that is inappropriately small. And that's going to cause a false elevation in their blood pressure. So you got to upgrade to the next one, which is usually like your purple cuffs, right? So you got to make sure the cuff size is properly sized. Something as simple as they have a full bladder can actually cause an elevation in their blood pressure. Upwards of 10 millimeters of mercury in both your systolic and your diastolic. So imagine just letting them go pee first, and then let's take their blood pressure, could lower their blood pressure upwards of 10 millimeters of mercury. So this patient who's like, 140 over 90 actually could be 130 over 80 simply by letting them go urinate. Okay. Other things are if they recently exercised, what do we like to do as providers? The medic, the tech, the corpsman will go out to the waiting room, call them in, and then they have to follow them through the maze of the clinic, sit them down, and immediately throw the blood pressure cuff on them. Maybe that maze is enough exercise to get their blood pressure up. So what can we do in order to ensure that that's not an inaccurate measurement because of exertion? We just give them time to sit and rest, ask them what's going on before I slap that blood pressure cuff on and inflate the cuff, right? Recent nicotine, recent caffeine, all of that can also do raise your blood pressure inappropriately, and we want to make sure that we don't assume they have blood pressure issues simply by something they eat. Okay, so when you have that patient who's identified having that abnormal blood pressure or that first check, counsel them about all these things. So when they come in for their second check, they're not repeating the same mistakes. Like they went to McDonald's on their way to your office and ate a double value meal, supersized, whatever, right? So make sure you counsel them about these things so that they can avoid those things before they come in for their second check. Okay. So you want to, when you do get a blood pressure that's abnormal, you want to verify that it is actually abnormal, right, in that first check. So what can we do? Well, let's let them rest for 5-10 minutes or so, and then recheck. And then if that is now normal, record that value. If it's abnormal still, then of course record that value, or if it's consistent between the two checks, record those values. But you've got to have that separation, because what happens if, as the automatic blood pressure cuff was inflating, trying to measure, they move or they twitch or something happens, it can give you that false elevation. So let's reset, let's just confirm that abnormal pressure. The most accurate way to diagnose somebody with hypertension is to do this thing called an ambulatory blood pressure monitor. You can see the picture here of what they look like, and it seems harmless enough, but the vast majority of primary care clinics will not have the capability of doing this. And the reason for this is, one, these machines are about $3,000 a piece. Two, you give them to the patient to use for 24 hours. You got to trust and rely that they aren't going to break it on you. And then they have to bring it actually back to your office again after that 24 hours of measurements. But it's the most accurate way to measure because I am going to take their blood pressure over the course of the day, doing their normal activities, normal routines, and then I can download the data that you see here on the chart or on the graph, and I can see how frequent or what's the percentage of the time over the course of that 24 hours that their blood pressure is above threshold. Is it just in the morning after they wake up and have their first cigarette, or they drink their 12 cups of coffee, or is it throughout the day? Or better yet, is it at nighttime when they're sleeping and they should have that lower blood pressure, simply because they're not having to work against gravity, they're resting and all that kind of stuff. So even though ambulatory blood pressure monitoring is the most accurate way to diagnose it, it can be also a very challenging way to diagnose it, simply because you don't have the resources to do it. There are clinics that you can refer your patients to. So if you have a patient that you are just kind of teetering on, well, is this white coat hypertension or not? Your MTFs will have a clinic you can refer to in order to get this done. You just have to justify it. So, but your primary care clinic, unlikely to be able to do this in their own. When we talk about preventative services, the USPSTF actually has recommendations on who to screen for blood pressure, okay? So they say the official guidance from the USPSTF is if you have an adult 18 years or older, 18 to 39, who is average risk, they recommend taking their blood pressure, and if normal, then every 3 to 5 years they get a blood pressure check. So this is not what we do in the military where you have to get your blood pressure checked every time you go get your periodic health assessment done, right? The USPSTF in a low-risk individual from 18 to 39, every 3 to 5 years is the recommended screening. So for ClinCore, You can always use this as one of your preventative services recommendations. So, tip. Now, if the patient is over 40, if they're high risk, African Americans, or they have another condition that puts them at high risk, i.e. obesity, then the USPSTF recommends annual checks, okay? So that is what USPSTF specifically recommends for hypertension screening. But when you have a patient who you suspect or you're going to give them a diagnosis of hypertension, do a history, do a physical, looking for evidence of causation. So is there any evidence of things like secondary hypertension diseases that we'll talk about tomorrow? Are those present? Because maybe I need to treat that condition as opposed to just simply putting them on an antihypertensive. There's a workup that is recommended that includes doing an EKG, which is great because you want to look at the conduction pathway. But you're also kind of assessing on is there any long-term or chronic changes associated with this blood pressure elevation? Do I see signs of left ventricular hypertrophy? Telling me that maybe this high blood pressure hasn't been going on for the last year, maybe it's been going on for the last 10 years, okay, right? Other things, blood glucose level, that's important because when we talk about determining what the treatment goal is going to be, we need to know if they have diabetes or not. And also diabetes does cause microvascular disease, right? And that can affect blood pressure. We're going to look at hematocrit. So do they have polycythemia vera? That's causing that blood pressure to be elevated. Let's look at their lipid panel because again, it kind of goes into the risk factors and it's going to affect our management. Let's look at calcium, serum calcium levels, because that's a cause of secondary hypertension. Let's look at their serum creatinine and kidney function, looking for, is this blood pressure affecting the actual function of the kidney, first of all. But two, if it's not affecting the function of the kidney, what is their baseline? Because the medications I put them on could affect their kidney function. So I gotta know if their kidney function is abnormal after I put them on meds, is it because of the medications or was it already their baseline and they already had kidney damage from this condition? Serum potassium levels are important, kind of goes along a secondary hypertension cause. And then finally, looking at urine microalbumin, kind of goes again to the function of the kidney. So that's the normal laboratory workup on that initial diagnosis of a patient with hypertension. Okay. Other things you may want to do, and it's going to kind of depend on the risk factors, but you could do a chest x-ray, especially if you're thinking if somebody has like coarctation of the aorta, or like you have a kid who has hypertension, then maybe you want to think about doing that, looking for that rib notching. Echocardiogram is always a great option to kind of assess for abnormal function of the heart, i.e. like regurgitation. Is that present because of that blood pressure elevation? But knowing also the risk factor is important. So we talked about obesity being a risk factor. Age, so the older you are, the higher the risk of you having hypertension. Diabetes, smoking, is there a family history? Do they consume excess salt or alcohol? Alcohol, especially above recommended limits, is cardiotoxic and can affect blood pressure. So what physiologic changes do we see that could be causing that blood pressure to be elevated? When we talk about primary hypertension or essential hypertension, where we said there's not an identifiable condition, we look at the different systems in the body to see how they could contribute to that blood pressure being elevated. So when we look at like the central nervous system, increased basal sympathetic tone, so somebody who's high stress all the time, probably some of you in here, right? That hypersympathetic tone can cause that blood pressure to be elevated because it's causing a vasoconstriction, right? A chronic vasoconstriction. Looking at The kidney, so what happens if the RAS system is not functioning properly? What is that going to do? And then there's other things local, like at the blood pressure, where maybe there's something going on with the ion channels that's causing those electrolytes to be abnormal, and maybe that's contributing to an excessive tone to the blood vessels at the local level. So lots of things can be present to cause that blood pressure to be elevated. Some we can do something about, and some we can't. So the kidney, though, ends up being probably the major contributor to blood pressure. And there's a couple of ways, there's 3 ways that this could be, the kidney could be causing this. It could be the failure to regulate renal blood flow appropriately, so reducing the blood flow coming into the kidney for some reason. The kidney is going to perceive that the blood pressure is low, so it's going to act to try to, in a self-preservation mode, it's going to act by trying to raise the blood pressure to improve that blood flow to the kidney. You could have ion channel defects, which that could be a genetic thing going on, or it could be inappropriate hormonal regulation. So there's a hormonal problem, whether it be like thyroid, that's causing blood pressures to be elevated. But to calculate blood pressure, the mathematical formula is you multiply the cardiac output by your total peripheral resistance. So that's a simplified version of what it takes to have a blood pressure. But look at all the different factors that go into those 2 variables, right? There's so many things that contribute to your blood pressure. The other thing that's amazing is the things underneath those categories in red are things that raise your blood pressure. The things in green are things that lower your blood pressure. So looking at this chart, what do you think is more life-threatening? Having a low blood pressure or having a high blood pressure? Low. The body has more systems in place to raise that blood pressure because it knows that if my blood pressure drops too far, I'm going to die because of hypoperfusion, right? But if I have an elevated blood pressure, unless it's like extremely elevated, I will be okay at this moment. Yes, 10, 20 years from now, maybe not, but right now, I will still survive, I will still be alive having a blood pressure of 180 over 120, right? So it's interesting to see how the body recognizes what's more important. But let's look at the cardiac output side of the house and see, particularly, let's look at the renal thing. So you have 3 things that increase renal retention of sodium and water to cause an increased blood volume. So you've got aldosterone, you have antidiuretic hormone, and you have your sympathetic nervous system. All 3 of those things will increase that volume to increase your stroke volume, which then increases your cardiac output. Okay. But you do have one of the few things on the cardiac output that actually lowers the blood pressure with your natriuretic peptides here, where the kidney can detect the pressure is too high in the kidney, let me secrete this and lower blood pressure. So it's one of the few things in the cardiac output that actually will lower your blood pressure. When we look at peripheral resistance, you can see, yes, you still have a lot of things that raise blood pressure, but you at least now have these local regulators where they detect that the blood pressure locally is too high. Let me secrete these things to decrease my tone. We have a vasodilatory kind of effect in the local blood vessel level to lower that blood pressure, because the blood vessels themselves recognize that having an excessive blood pressure actually does harm. Okay. So that's the pathophys of hypertension. So the question then is, how do we treat it? Who do we treat? What's my goal? And the question about what my goal is dependent on which society's blood pressure guidelines you follow, okay? They all have different values. You can see, like JNC kind of says most patients 60 years or older, they're okay with their blood pressure being in the 140s over 80s. Really not, like, they don't really want you to treat below 150 over 90 in patients who are 60 years or older. The International Society for Hypertension, if it's 65 years or older, then they say treat to below 140 over 90. So 130s over 80s is okay. What's interesting is when you look at the ACC/AHA guidelines, they don't factor in age. There's not an age-specific thing. And the reason for that is what do they focus on? They're focusing on ASCVD, atherosclerotic cardiovascular disease risk, okay? Which age, we'll talk about it in our lipid disorders, age is a factor in that calculation. So they do to some degree, but they don't make a blanket statement like the other societies say, where anybody over the age of 60 or 65, then those blood pressure goals are no longer applicable, okay? So let's look at the ACC/AHA guidelines a little better. So they say that it is recommended, not required, but recommended, it's recommended for anybody who has a 10-year ASCVD risk of 10% or higher, they recommend getting their blood pressure lower than 130 over 80. So 10% ASCVD, so in the next 10 years, they have a 10% risk of having a heart attack. Get their blood pressure less than 130 over 80. That's what they recommend. But looking at patients who have an ASCVD risk that is less than 10 years, and they don't have any additional risk markers, then it's reasonable to get them less than 130 over 80, but not a requirement. So in somebody with a ASCVD risk less than 10, it's okay if their blood pressure is in the 130s over 80s. Just try to keep them out of the 140s over 90s. Okay. And then if you wanted to see how you calculate, which again, when we talk about lipid disorders, we'll use this ASCVD calculator. But if you wanted to click on it, play around with it, put your own information into it, there's a link for that calculator. It's also available in like MDCalc that you can download free in the app stores. So that's our goal, or that's our goals that we're going to shoot for, right? But how do we get there? Well, what happens if you have a patient who doesn't want to start on meds or is hesitant to, can't afford to? What are things that they can do to help lower their blood pressure with lifestyle changes? And you can see on this list what in the literature the expected change in blood pressure is going to be if that patient were to do that specific lifestyle change by itself, okay? So if I lose weight, ideally you lose 1 kilogram reduction in body weight for most adults who are overweight. Expect about 1 millimeter for every kilogram reduction in body weight for an average of about 5 millimeters of mercury drop in blood pressure simply by losing weight by itself. But let me add a healthy diet, and particularly the DASH diet. You can see it has the greatest effect on your blood pressure. And we'll talk about the DASH diet in a couple of slides. But I can expect if a patient implements the DASH diet appropriately, they should have an 11 millimeter of mercury drop in their blood pressure. So let's say I had a patient who's like 140 over 90, they implement the DASH diet, you could get them less than that 130 over 80 without any meds. Kind of sounds ideal, right? Let's decrease sodium, about 5 to 6 millimeters of mercury. Let's enhance intake of dietary potassium. That's 4 to 5% decrease. Let's start exercising. You can see the second largest change in blood pressure is present if they do aerobic activity at least 90 to 150 minutes a week with a 65 to 75% heart rate, where they achieve that 65 to 75% heart rate. So and these are just isolations, but let's have this patient do DASH diet and exercise at least 90 to 150 minutes per week. I'm now expecting 16 to 19 point difference in their blood pressure. Again, no medications, just lifestyle changes.
Yeah. So let's say you have a new patient come to you from a different duty station, whatever the case is. They're on medication, stage 1. Does it work the same? The same scenario is like, all right, well, maybe their goal is to get off medication, less pills to take. Could you transition them to this in the hopes to take them off their hypertension medication?
You could, yeah. Let's say, because kind of the biggest thing is when you start talking to a patient after a new diagnosis like this, there's two things that are going to happen. Either they're going to be in denial that's happening and they're not going to listen to anything you say, or they're going to freak out and they're going to do everything you tell them to do. So if you have that patient who's like, I'm fine, I'm not going to stop smoking, I'm not going to start exercising, I'm not going to do any of those things. But then later they have a scare, like a family member has a heart attack or something, and now they have that scare and they want to implement these changes. Even though they're on meds, you can have them do these lifestyle changes with the understanding that you're going to want to follow up with them in like a month or 3 months, and then potentially titrate the dose down on their antihypertensives as they start losing weight, as they start exercising, as they start following an appropriate diet. But yeah, you can, if they've started on meds, but they aren't doing these lifestyle changes, then absolutely you can still do these things with the anticipation and expectation that you may have to lower their dosages or get them off entirely. Oh, another question. Right. So, smoking cessation. This is an important avenue because, one, there's so many other cardiovascular diseases, smoking is a major risk for it. But the nicotine itself in tobacco and tobacco smoke can cause or does cause a transient increase in your blood pressure. How many people smoke 1 cigarette a day? Right? How many people smoke 1 pack a day? Which is what, 20 cigarettes or something like that? So imagine if I had a transient increase in blood pressure for 45 minutes after every cigarette that I smoke, and I'm smoking 20 cigarettes in a day. It's 45 minutes times 20 equals how much time your blood pressure is elevated because of that nicotine. Okay? So smoking cessation has a direct and almost immediate impact on lowering blood pressure. Stress management's a big thing. That sympathetic nervous system, that hyperdrive of the sympathetic nervous system in high stress environments causes your blood pressure to be elevated for extended chronic periods of time, right? But if I implement stress relieving techniques like yoga or anything else that causes somebody to de-stress, then those things can have a direct, immediate effect on that vasoconstriction, on that tone of the blood vessels themselves, and also the cardiac output. So you're addressing both sides of the equation. Caffeine reduction, we say it, but you get a temporary increase in your blood pressure. But how many people are drinking coffee throughout the day or caffeine throughout the day? There may be some, but most people, they drink their coffee in the morning, and then by 8 o'clock it's out of their system, and now they're not having that effect on their blood pressure. So caffeine reduction, although important, maybe doesn't have that immediate effect like we see with some of the other changes. But it's reasonable to recommend reducing caffeine use. The DASH diet is the most potent lifestyle change in reducing your blood pressure. I always thought DASH meant, a little bit of this and a little bit of this, but actually it's an acronym for something that says Dietary Approach to Stop Hypertension. And when you look at what it recommends, it's eat more fruits, eat more vegetables, reduce your fats, eat your lean proteins. So it's kind of like that food pyramid that we all grew up with, right? So just eating healthy can lower your blood pressure, which probably part of that is going to be also you're going to lose some weight. But ultimately, eating healthy will reduce blood pressure. It has the most potent effect of lowering blood pressure. But what happens if you have a patient who refuses to make changes? Because remember, obesity is a major risk factor for hypertension. That's not something that just happened overnight, right? That's something that they've made an effort or they've made a decision to eat excessive amounts of calories or inappropriate sources of calories or not exercising and or not exercising, right? They've made those decisions to get to that point. So those folks may not want to make these changes in their life to treat their blood pressure. So they may need medications to do this. So what do we have at our disposal? There's lots of broad categories of medications that can be used. And there's certain situations where you may choose one of these over another. But we got to look at how these things, how these agents actually interact with the systems that regulate your blood pressure. And you can see they're all over the place, both on the cardiac output side of the equation, but also the total peripheral vascular resistance side of the equation as well. So you can see if I put somebody on a calcium channel blocker, I'm going to expect to see the impact on the peripheral resistance, but I'm also going to see an impact on the venous tone over here for the cardiac output side of the house. We're going to see potentially a decrease in contractility and maybe even a reduction in their heart rate. So calcium channel blockers themselves can interact and affect the different variables that regulate your blood pressure in multiple stages. Okay. But ultimately, based on that list of all the medications that we could use as antihypertensives, your primary agents or your first line agents are going to boil down to these four categories, okay? And we'll talk about each one of these categories, but you got your thiazide or thiazide type diuretics, not your loop diuretics, but just your thiazide diuretics. You have your ACEs, you have your ARBs, and then you have your dihydropyridine calcium channel blockers, and we'll talk about each one of these categories. Actually, that brings us up to 50 minutes, so let's go ahead, take 10 minutes, come back.
I don't care at this point. Like, if we're done early, we're early. Sophomore, if I get like next break. Good on that.
I mean, it's not like you do it 2 times and you're gonna fucking get it.
I'm supposed to relearn everything that people taught. I don't know if I can adjust it as I type with as I move. It's just so confusing. Dude, I watched, me and Mario watched 2 episodes. No, I just, the first season, we just started it. She likes it. She was a medical assistant for a while, so she liked it. It's been a long time. It actually made me feel good. I get like kind of and I was like, oh, you're gonna do this, and then they like the pericarditis and disease. They were like talking about it. Pericarditis. And then like 12 seconds later, they said it.
Be right for that. Make sure you spell that out.
Is that what your problem is? Or are you sick?
I've never had it.
You do look a little swollen, everybody. Healthy as that.
I knew it last week. I really wasn't good. I feel great. So it makes it
I always get this weird like, lower back pain where it's like,
That was last week. You still have issues. It was like all over the mom. That's how it yeah.
I don't mean to laugh at your suffering, but
It's not even that bad. It's just like
it didn't seem that bad downstairs.
it comes in waves.
Yeah.
Dude, it's fucking expensive.
You're allergic. You're allergic. The building's been 16.
That's right. It's alright. It's alright, Brad.
Yeah, so I was like, talking about like very. Especially if someone takes a year off. Although you weren't this PG, so this dude, he retired. I just started this is what he was acting like KGR. So he got a full active news and something. Graduated in Houston, that's got all first residency. He's got both. He's like 48, 49. He's just out of like residency. I'll do a Craig. 100% for Craig. You say you can't make it. We have 10.
I looked at it.
Hey guys, what's up? Another video here.
Smash that like button.
Subscribe to my Google Plus.
I didn't do it on the I got lucky too. The small docks and this is me.
I think that's
I saw clips of it.
So, I actually, but I want to do that.
Go, your boss.
I can. I don't even. They never. They never quote people who just like watch football large because they're trying to bring in like there's always someone who like they want to bring in non-football. Dynamic work. I get it.
Yeah. I really like the mashup though.
I don't know.
Yeah, the one I remember it was like salsa fight. I didn't know. It was not very serious. I didn't know. I still get some clips.
You didn't watch it live. You didn't see like.
Yeah. Yes, you like when you listen. I could watch it, but I was not. Why you actually just like it when they're slowly getting up there.
How long are those?
This one's called T20, so it's only 20 hours. That means
It was just like, kind of like, how
It's like.
because the match was in PBS. So people
the mountain.
from the bus.
Yeah, is it like
There's a team from the US too that's nice. A lot of people from the US team that are Indian, migrated. Almost the early US team was
Suck here, we're looking at hard.
the amount of money provided
Dude, it's getting to that.
to soccer? Which creators in a week
Can't go anywhere.
All right, let's go ahead and get back to it. So before break, we talked about how we have 4 main groups of antihypertensives that are considered our primary or our first-line agents. So what does that mean? That means when I have a patient who I need to start medications on, unless there is something else like secondary hypertension that we're going to talk about tomorrow, the agent you choose should be one of these to be within standards of care. Okay? We'll talk about historically some of the other ones and special circumstances where maybe a different grouping is needed or is necessary, but one of these 4 should be your primary or your first agent you do. So let's talk about ACE inhibitors. So I know you've talked about the renin-angiotensin-aldosterone system, the RAS, RAAS or RAS, either way. But this system, it's not just one organ that regulates the blood pressure. This system requires multiple organs to have that effect to regulate your blood pressure. So you have to have the liver producing angiotensinogen, and that just circulates around in the blood. Well, the kidney detects that the blood pressure is not appropriate, perfusing itself, so it causes renin to be secreted. Well, that renin then starts to circulate in your blood, and then it starts to interact with angiotensinogen and converts it into angiotensin 1. So now you have all this angiotensin 1 circulating in your blood. Well, the lungs then produce angiotensin-converting enzyme, ACE, which then cleaves angiotensin 1 and makes it into angiotensin 2, which is now the active form of this chemical. And that angiotensin 2 actually has 2 ways that it impacts your blood pressure. One is it works on the total peripheral or vascular resistance side of the equation, where it causes a vasoconstriction by interacting with those angiotensin 2 receptors. It also then goes down to the adrenal gland, which then causes the secretion of aldosterone, which then goes to the kidney, and it causes that reabsorption of water and sodium to increase your volume, your venous return, which increases your stroke volume, which increases your cardiac output. So you can see this system regulates both sides of the equation. Okay? But if we have somebody who has excessive blood pressure, do we really want this system to be acting unchecked? And the answer is no, right? This has a large component to your blood pressure, and if I have a patient who has an elevated blood pressure, maybe I need to start addressing that excessive amounts of these systems, or these chemicals. So ACE inhibitors, they work by blocking that conversion of angiotensin 1 into angiotensin 2. So you're blocking that formation of that active form of this system. So what that means then is it blocks the vasoconstriction and it blocks the secretion of aldosterone. So that's how ACE inhibitors work to lower blood pressure. But it also has another thing where your body will have this bradykinin kind of circulating in the system. And bradykinin can cause the secretion of nitric oxide which is one of the local factors that can actually decrease your blood pressure by causing that vasodilatory effect at the local level. But there's a system in place where bradykinin is broken down into inactive peptides and then disposed of. But ACE inhibitors can actually go in and they block that degradation of bradykinin, which then increases your levels of circulating bradykinin, which means then it's increasing the local secretion of nitric oxide, which is having that vasodilatory effect. So now you're seeing we're blocking angiotensin II from causing vasoconstriction, but I'm also now blocking the conversion of bradykinin to inactive, so I'm increasing the secretion of nitric oxide, which then has a vasodilatory effect. So I stop the vasoconstriction and I encourage vasodilation. So that's how ACE inhibitors can work. ARBs, on the other hand, angiotensin receptor blockers, they block the angiotensin II from binding to the receptors that cause that vasoconstriction, and they block to the receptors in the adrenal gland, blocking and stopping the secretion and production of aldosterone at the adrenal gland levels. So it works those two ways, but it doesn't do anything to the bradykinin conversion. So less effective in some ways than an ACE inhibitor is. But we'll talk about side effects, how you would want to use an ARB over an ACE inhibitor when we get to the side effects part of that. But another thing I wanted to highlight is ACEs and ARBs in a patient who is pregnant or is desiring to become pregnant should not be given to this patient. Okay, ACEs and ARBs have fetal harm. You don't have to memorize what the fetal harm is, but just know ACEs and ARBs can cause fetal harm. So if you have a patient comes in and they have a positive pregnancy test and they're on an ACE or an ARB, you need to stop it immediately because it can increase harm to the baby. So what do you have at your disposal? We'll talk about all these agents, but you're looking at things like methyldopa, labetalol, and nifedipine that you can give to those patients, and it is thought that it is safe for the pregnancy. Okay. But stop ACEs, stop ARBs in pregnant or women who are desiring to become pregnant. So let's look at the side effects of ACEs and ARBs. Let's look at the second one, renal insufficiency. You can see under the ARBs category, it's there. Hyperkalemia. If you look over at ARBs, it's there. If you look at angioedema, which is what's here in this picture, ARBs can cause that too. Hypotension, it's over on the ARB side too. So all of those side effects are present in both ACEs and ARBs. But the one that is not present in ARBs is cough. And the reason you don't see like that dry cough, irritating cough in ARBs is that cough is because of the bradykinin levels. That higher bradykinin levels triggers that cough. And we said that ARBs don't affect the levels of bradykinin. So most common time that you're going to use an ARB is somebody who has that cough with ACE inhibitors that is too annoying that they want to stop their medications. You can transition them to an ARB and that will go away. Now, if they're coming to you because they have an angioedema side effect, then you're not going to transition them to ARB because they most likely are going to have that side effect as well to the ARB cell. But cough is the most common reason somebody cannot tolerate an ACE inhibitor and will get switched to an ARB. Okay, diuretics. There's three main classes. Loop diuretics, they're the most potent ones, but we're not going to talk about them in our hypertensive lecture. We're going to talk about those in our heart failure lectures in block 3. Thiazide diuretics, or thiazide-like diuretics, are the most common ones, and remember those are one of the first-line agents, right, for treating blood pressure. And then there's the potassium-sparing diuretics, which we'll briefly mention, but those will be important in tomorrow's discussion when we talk about secondary causes of hypertension. But you can see on this diagram of a nephron in the kidney where these things work and what to expect is going to happen. So if I'm looking at thiazides, looking for number 4, we're in the distal convoluted tubule, and it causes you to secrete sodium and chloride, which means then water is pulled with it, right? So it's a diuretic, right? It makes you pee. So it's pulling water with that sodium and that chloride. If I'm looking at potassium sparing, number 5, I'm looking at the level of the sodium ATPase pump, which by blocking that aldosterone effect, I will reabsorb potassium, I'll reabsorb hydrogen, but I'm dumping sodium and chloride. Okay, so I'm dumping water with it. So we said thiazides, they work in the distal convoluted tubule. They work by lowering the blood pressure by getting rid of sodium and water. But one of the reasons that thiazides are so popular and why they are a first-line agent is, one, I actually get some benefit, so I can expect at least a 15 to 20 millimeter drop in their blood pressure. But based on studies, I can reduce morbidity and mortality from cardiovascular disease using a thiazide. So in addition to having a numbers response, I'm also having a condition response, positive response, where this patient's having less morbidity and lower mortality rates related to their blood pressure. You just have to be careful, though, with the use of these, because if it works by me peeing out extra volume, if I have somebody who already has pretty poor functioning kidneys, I'm not going to have the same effect on lowering that blood pressure. So you got to be careful as that patient's kidney function declines. You may need to transition to something else. The other thing that you have to be careful of with thiazides is the electrolyte changes. If I'm dumping sodium and chloride, then does it make sense that if they're on this for like a long period of time, I may be getting to the point where I'm dumping too much sodium or too much chloride or even too much potassium, and now those electrolytes become deranged. What are the secondary impacts of having an electrolyte abnormality in any of those things? It kind of depends on the organ system that you're focused on. But just knowing that those electrolytes are going to be affected by being on this medication, you need to monitor them closely. If you have somebody who has gout, probably not the agent that you're going to want to put them on, because it can increase their uric acid levels, which then means you're precipitating more frequent gout flares. Okay? Your diabetics, maybe not the agent of choice, because it actually can cause your glucose levels to go up a little bit. Okay? So making sure you're prescribing this agent to the correct patient is important, because you could make their conditions worse. Potassium-sparing diuretics. Excluding one thing that we're going to talk about tomorrow, this is not a primary treatment for blood pressure. And the reason for it is, one, it doesn't necessarily work as well as the other first-line agents for lowering blood pressure. But two, there is side effects associated with the use of potassium-sparing diuretics. So if I happen to have them on an ACE or an ARB, and I put them on this agent, I could precipitate hyperkalemia. Now I've got two different medications that are increasing your potassium levels. Okay. So be careful prescribing this in patients who are already on ACEs or ARBs. Probably one of the biggest effects is going to be this antiadrenergic effect that you see, where if you put men on spironolactone, it can cause gynecomastia. In women, this is actually a very common medication that we use in the management of PCOS and the hirsutism, so like that excess facial hair growth present in PCOS, because it has this antiadrenergic effect to it. You can also see this used in patients who have resistant acne, female patients with resistant acne, where we lower that testosterone levels and then their face starts to clear up. So a little trick that you can use if you need to in those patients, because it has those antiadrenergic effects. But not something you would want necessarily to use in a male patient, because then it can cause breast tissue development. Okay. And then remember, our last category of first-line agents is your calcium channel blockers, particularly your dihydropyridines. Okay, so your peen medications, amlodipine, nicardipine, nifedipine, felodipine, all of those are your dihydropyridines, and they work much better at being an antihypertensive. Now compare that to your non-dihydropyridines, which is your verapamil and diltiazem. These have much more of a cardiac function effect and less of a vascular tone effect. So we use verapamil, we use diltiazem a lot in regulating heart rate and cardiac output. We don't use those as an antihypertensive, okay? Because it doesn't have as much of an effect as the dihydropyridines, calcium channel blockers do. And these calcium channel blockers, the way that these work is, if you recall, what is the one electrolyte that is necessary for muscle contraction or can impact muscle function the most? Calcium, right? What is your blood vessel wall made of? Muscles. So calcium muscles go together for contraction, for constriction, when we talk about it in the sense of a blood vessel. If I block or I delay that calcium level from coming into the walls of the blood vessels, so that the muscles that regulate your tone aren't getting the calcium that they need in order to function, it's going to have a vasodilatory effect. Okay, so that's how these calcium channel blockers work to lower blood pressure. The most common side effect that's going to cause somebody to want to stop this is going to be your ankle edema. And it can be pretty significant, okay? To the point where it almost looks like they're having heart failure because of how edematous those legs can be, especially if they're doing jobs where they're on their feet for extended periods of time. So those were our primary agents. But recall, when we showed all the different things that can impact your blood pressure, there were other classifications on that list that we have to be aware of, because even though these are not first-line agents, does it make sense that if medication A has an effect on blood pressure, and I give it to a patient who is already on 3 different antihypertensives for some other reason, does it make sense that that medication is going to impact blood pressure too? So I could have it where I've got an elderly patient with BPH, or benign prostatic hypertrophy, who comes in, he's on 3 antihypertensives, blood pressure is controlled, But now he's having those BPH symptoms, and you want something for that, so I put him on an alpha-1 blocker. Now he's peeing better, but now his blood pressure is too low. So I put him on now basically a fourth agent to regulate that blood pressure. So you can see, even though these are not typically thought as antihypertensives or utilized as first-line antihypertensives, these medications can still impact your blood pressure. So you've got to be careful in the use of these patients, okay? So alpha-1 blocking agents are kind of one of the more common ones that we use, but we usually use these in our male patients with BPH. They can be used as an adjunct for patients who are difficult to control, but it's a regulated kind of medication. Alpha-2 agonists. These are your methyldopa and your clonidines. If you remember the list of what are considered safe medications for pregnancy, these agents are there. So you would think, okay, maybe those should be primary agents, right? The unfortunate thing is, you got to factor in the side effect profile with these, which unfortunately you have the anticholinergic side effects. So they have dry mouth, sedation, constipation. Who wants to have those side effects, right? So we typically only use alpha-2 agonists in pregnancy, hypertension in pregnancy, or if they have a hypertensive crisis, which we'll talk about tomorrow. But those are the only two situations that we use alpha-2s currently. Beta blockers. So you have your labetalol, which kind of think of that more as a antihypertensive agent, right? Because it has much more of a profound hypertension effect than it does on heart rate, like metoprolol does, or some of the other beta blockers do. But we typically don't use beta blockers as our first line unless it's labetalol in pregnancy, because we have better agents. But does it make sense that if I do have a reason or an indication to start them on a beta blocker, that it could affect their blood pressure? And it could affect their blood pressure up to 10 to 20 millimeters of mercury. So that can have a profound effect. But it also has a very profound effect on lowering heart rate. Which means then it can set them up for having syncope or presyncopal episodes. You could get somebody with asthma, you can precipitate a bronchospasm. It can cause insomnia, depression, impotence, so sexual dysfunctions. So there's a lot of side effects that kind of go along with beta blocker therapy, which is one of the reasons why we don't use these first line for hypertension. And then you have the direct-acting vasodilators like hydralazine, which we typically will use in pregnancy and other hypertensive emergencies, okay? Which, again, we'll talk about those tomorrow. But these have a direct effect on the blood vessels themselves, causing them to dilate. It's a vasodilator, okay? But it has that direct effect on it. So the question is, then, okay, now I know lifestyle choices to treat. I know which medications I can start them on. Well, how do I implement these things? And the ACC/AHA guidelines, granted, these are from 2017, which is what you're going to be tested on with your pants. If you've been reading the literature in August of 25, they actually came out with a new set of guidelines. Didn't change a whole lot, but they changed some definitions and they changed which calculator you use. As far as your treatment goals, there really wasn't much of a change in what to do. But there is an algorithm to help you determine how to best manage this patient. And you can see, okay, if somebody has stage 1 hypertension, which remember, ACC/AHA is anybody from 130 over 80 to 139 over 89. That's stage 1. If they have that, and you do your ASCD 10-year risk calculation, if they are less than 10%, then do non-pharmacologic therapy, reassess in 3 to 6 months. If they have an ASCVD greater than 10, then non-pharmacologic therapy and a blood pressure lowering medication, reassess in 1 month. Okay. But if they have stage 2, meaning that their blood pressure is greater than or equal to 140 over 90, then they want you to immediately start them on lifestyle changes, but they also want you to start the patient on pharmacologic therapy, reassess in 1 month, and see if it's effective. If not, getting them down to goal, then we need to add additional medications or increase dosages to those meds. And this is just kind of a quick summarization of that algorithm. So stage 1, do this, stage 2, do this, first line we already talked about. Special patient populations where maybe you need to rethink how you prescribe. So our African American patients tend to not respond to ACE inhibitors from a hypertensive standpoint as well as other populations do. So maybe an ACE isn't appropriate as a first line, as monotherapy. Maybe we should be thinking more along calcium channel blockers or thiazide diuretics as a better option to control their blood pressure. For pregnant patients, we talked about no ACEs, no ARBs. For your diabetics, because of the renal protection that comes along with ACEs and ARBs, maybe that should be our agent of choice in a diabetic patient. But you're going to have a lot of patients who are going to need more than one medication in order to get them down to goal. So how do you manage, how do you do 2 agents? Well, fortunately, literature has shown there's 3 different strategies you can use. One is start them on both agents right away, and then follow up. Personally, not the way that I practice, and I'll explain why. The next way is start them on one agent, titrate the dosage up to max tolerated dose of that agent, and then add a second agent if necessary. The third way is start them on one, see if they tolerate, but don't titrate the dose necessarily. Start them on the second agent, and then slowly titrate both agents up until they're at goal. Okay. The reason in my practice I don't do start 2 agents at the same time is for a couple of reasons. One, if this patient's been used to having a blood pressure of 150, 160 over whatever for a while, does it make sense that the body kind of has adjusted to that as the normal blood pressure, right? Well, if I throw 2 agents at them, and now I get them down to 120s, they are probably going to have side effects of syncope, presyncope, because now their blood pressure is too low for what their reset is. Okay, so I want to slowly bring that blood pressure down to avoid those undesirable side effects. So that's one reason I know. The second reason is if I start them on 2 agents, they start having side effects. How do I know which one is causing the side effect if I started them at the same time? You don't. So now how do you know which one to take off or change? You don't. So now you're kind of guessing and hoping that the side effect that they have, it gets better with taking that one agent away. So that's the reasons I don't start 2 different agents at the same time. And that's why I typically will do start one, follow up a week, start a second one if they're tolerating it okay, and then slowly start working the dosages up. So that's my personal practice. But literature says you can do one of those 3 approaches and you're still within standards of care. Okay. The nice thing about if a patient needs more than one medications to manage their blood pressure, is there's lots of combination pills out there to help you to reduce the number of pills that that patient has to take. Compliance is always going to be a concern in any patient with a condition. So if I have to give this patient 2 pills a day, but they got to take them at different times of the day, how compliant are they likely to be? Probably not, right? But if I give them a pill, one pill, that has both of those medications in it, and they only have to take it once a day, that compliance will go way up. They're going to be able to easily remember to take their one pill in the morning when they wake up, or that one pill, take it before they go to bed kind of thing, right? So there's different types. So you have combos of ACE inhibitors and diuretics, ARBs and diuretics, beta blockers and diuretics, calcium channel blockers and diuretics, calcium channel blockers and ACE inhibitors, and then you even have the diuretic-diuretic combo where you have a spironolactone combined with hydrochlorothiazide. So if you needed that dual diuretic kind of effect, they work different. They're different diuretics, so you can give them that and have an effect. So there's lots of different variables, or a lot of different options out there in order to help your patients who need 2 agents. Here's some other specific conditions on medications that you can give or should give to them for their hypertension. So if they have hypertension and heart failure, then be thinking these meds. If they have hypertension and they've had a heart attack, be thinking of these meds kind of things. This is also in the AACC-AHA guidelines. So you have a patient who has hypertension who also has chronic kidney disease as diagnosed with albuminuria. Then ACE inhibitors should be considered your first line. And if they can't tolerate an ACE, then they should be put on an ARB. So that is the algorithm for your patient with chronic kidney disease. But if you have a patient who you're giving them medications, and they still are not controlled, you don't want to do anything like accusatory, you're not listening to me, you're not taking the medications I'm giving you, or anything like that. Because if you become accusatory, you kind of shut off that patient-provider relationship, right? So don't sit there and be like Tom Cruise demanding the truth from them, because you've ruined any kind of outlet you have to make change. So what can you do? Well, first of all, sit down and have a serious conversation with them. Hey, I am concerned because your blood pressure is not being controlled with the medications that I'm prescribing. Are you taking them properly? Is there any confusion on how do you take these things? And you can ask those questions. If they're like, I don't want to take these meds, I feel fine, I'm not having any symptoms, I don't believe you that I have blood pressure problems. Well, maybe get their family involved, right? Spouses have much more of an impact on their loved one's health than their provider does, right? Because we are not in their home watching them take their medications. So get somebody on board with you to do that, right? Maybe if you have them on a regimen where they have to take 2 or 3 pills over the course of the day, maybe you could tailor it so they can only have to take 1 a day, but have that 24-hour effect. So help them manage their conditions. And then maybe if they don't believe you, then maybe getting other providers involved. So send them to cardiology, who can do all other kinds of things like echoes and stress tests and those types of things to show, yes, you don't technically have any symptoms right now. However, on your echo, I'm already seeing a decline in your heart function because of this. Showing them that, getting that information may be enough to induce change and compliance. Okay? If you do have a patient and they insist they're compliant with their medications, then maybe you need to send them to other experts like nephrologists or cardiologists, endocrinologists, in order to have them do their own evaluation to see, is there maybe a secondary reason for this blood pressure control difficulty? Maybe they have a secondary hypertensive patient that we have not diagnosed, but they can, with their toolboxes, or with their tools in their toolbox, maybe they can help us diagnose that secondary cause of hypertension. But you've got to treat these things, okay? And there may be other things that we need to do differently depending on what is present. But you've got to, regardless of which antihypertensive you start them on, you have to monitor their electrolytes appropriately. You can see this list of what types of electrolyte derangements we may see if the patient is on this medication. And you can see a lot of these are redundant. So there's impacts on your potassium levels. Some go up, some go down. There's impacts on sodium. Some go up, some go down. And fortunately, these two variables, you can easily check by doing just a basic metabolic panel or a Chem7. It will have those values. The only value that the Chem7 or BMP does not test for is magnesium. So if you have somebody who's on a loop diuretic for heart failure, then you're probably going to be needing to add testing for magnesium to make sure that their magnesium levels are appropriate. Okay. So let's go back to our clinical case. So after being admitted to the ICU, this patient's blood pressure slowly came down. They transitioned her to a new oral regimen, which brought her blood pressure down to systolics of 160s, and they thought it was okay for her to get discharged and sent back to her primary care provider for further management. She continued with 3 antihypertensives, max dose, and she continued to have problems managing or getting her blood pressure down to goal. Now she had kidney stones, and she went to go see her urologist, and the urologist, quote unquote, said, "I remember studying a condition in medical school where hypertension and low potassium went together, but I can't remember what it was. Let's send you to a nephrologist." And they ended up diagnosing this patient with Conn syndrome, which we're going to talk about tomorrow, which is a secondary form of hypertension. They put her on, they couldn't find out where the tumor was necessarily right away that was causing this hypersecretion of aldosterone. So they ended up putting her on spironolactone, which we talked about, and it actually caused a reduction in her, the best reduction in her blood pressure. Years later, she had appendicitis, was seen by the ER, they did a CT abdomen and actually saw the tumor, and then she had the adrenal gland removed, and her blood pressure was much better controlled. But because this had been going on for 25 years, the damage was done, so she still needed antihypertensives in order to manage her blood pressure. And that was the story of my mother. So for years, and my mother is very particular about listening to everything a provider tells her to do. So she was taking all of her blood pressure meds appropriately. If they wanted to change something, she followed it to a T, and she still could not control her blood pressure. And it wasn't until decades later, because somebody was like, I remember talking about this, that it actually was properly diagnosed, but unfortunately the damage had already been done, and just simply getting rid of the aldosterone secreting tumor was not enough to control her blood pressure without medications. So. Questions? Okay, so believe your patients when you can. If they give you reasons not to trust them, then okay, yeah. Like if you say, you look and they're not picking up their medications, then you can address them with that.